Assalamu alaikum. My thanks to Brooks Pharma for inviting me for this talk. I'm not an expert user of dexmedetomidine. I've used it a few times, but not more. So it was launched in UK in 2011, and 2013 was the time that we were coming back. So there's no way I can claim that I'm an expert user of it. So I'm here not to teach, I'm just here to share what I know. So it's supposed to be a very versatile drug. It was described in '99 and then clinically started to be used fairly straight away then. But FDA did not approve it until quite recently. I think that was 4 or 5 years ago when FDA actually approved it. And it was 2011 when UK approved it. So approval came much later, but the clinical use was established earlier than the actual approvals came through because of the promise that this drug had for the clinical uses. So what does it do? So this is a alpha-2 agonist. So another alpha-2 agonist that we all are familiar with is clonidine. It works pretty much in the same sort of fashion. The only difference is it is extremely selective. It is highly selective. It does not act on any other receptors. It loves alpha-2 and it goes and works on alpha-2 receptor. So by virtue of working on alpha-2 receptors, this is how most of its actions are manifested. It is short-acting and mainly used as an intravenous anesthetic agent. It has been used as an intramuscular agent as well, but mainly it is described as an intravenous anesthetic agent. It also has a basis, so just as a comparative statement, on alpha-2 it works on 16-20 times to 1 in comparison to alpha-1. So what it means is that there is very little effect on elsewhere. So the main effect remains on alpha-2 receptors, and that is its main advantage. So mechanism of action is pretty much the same. G-protein coupled protein receptors. There are three different sort of G-protein coupled receptors where it works: A, B, C, and it works pretty much in the same. The mechanism of action on all these receptors is the same in terms of how many receptors are occupied, and in terms of the sensitivity to these receptors, they are all the same, so they are no different. So like opioids, you have mu receptors, kappa receptors, and one drug is acting a bit more on the mu, the other one is acting a bit more on the kappa, and hence the difference in their mechanism of action, and hence the difference in what they clinically do. This drug acts equally on these receptors, and hence we get all the advantages. So where are they found? They are found in the central nervous systems, the peripheral nervous systems, that is the peripheral nerves as well as the spinal cords. And that is the advantage that these receptors are mainly present everywhere in the body, and hence this drug can manifest itself. So the brain, the spinal cord, the autonomic nervous system, and organs such as heart, muscles, and intestines. So all these areas have got alpha-2 receptors. Protein binding is 94%. So what it means is that we have to give a loading dose. And because of the population that we look after, we cater to, we have to be careful because of the high protein binding. If the protein binding is less, the amount of drug that would be available to the body would be more. So when it comes to the loading dose, we'll discuss it a little bit more. So this is metabolized in liver, and then inactive metabolites are excreted in the kidney. So there is no active metabolite. That is another big advantage of this drug. So once the liver is functioning, if the liver is functioning, it will get metabolized. And if it gets metabolized, then there is no issue of active metabolites getting out of the kidneys. Whatever the metabolites are, they are inactive. Even if the kidney is not functioning properly, you can still use this drug because inactivity of those metabolites. There is no difference between the pharmacokinetics for a young child and an adult. That is another major advantage, that it does not depend on how much the liver is functioning or how much the kidneys are well developed. As long as there is some function, this drug will do the job. So the ampule comes as 100 mics per mil, and there is 2 mils of ampule. The ampule has 2 cc in it. So there are different ways of how to do this, but the prescribed way is to dilute it in 50 mils, whether that is normal saline or that is 5% dextrose, it doesn't matter. So once you've diluted in that strength, then you start using that. The loading dose is from 0.5 micrograms per kg to 1 microgram per kg. So for a 70 kg adult, we either give 35 mics, or we give 70 mics. So this is where the concept of protein binding comes into play. So if we think that the patient is emaciated, patient doesn't look that well formed, then remember the protein binding would be less and the amount of drug available will be more. And hence, probably erring on the side of caution, this 1 mic should then be converted into 0.5. Give a lower dose and then see how it responds, how the patient responds, and then if you want to increase the dose, do that. So this is fairly simple, 0.5 micrograms per kg over 10 minutes. And then the maintenance is 0.2 to 0.7. So just for the sake of ease, loading dose is 0.5 to 1, and then you can maintain the patient at 0.5 mics per kg per hour. Very simple. Which would come to 4 to 9 mils an hour, so it won't be more than that. So if you imagine that you have a patient who's got 48 mils diluted, so this infusion is going to last quite a long time. And you can titrate it over this much. The recovery time is 10 to 12 minutes. So we need to be cautious in renal disease, hepatic disease, elderly patients, emaciated patients, cancer patients, immunocompromised patients, uncontrolled diabetes, obstetric patients. So the vulnerable population that we come across in our daily work is the vulnerable population for dexmedetomidine. It's not any different. Uncontrolled hypotension, because this will cause hypotension, so it is uncontrolled. Yes, if some patient is already in shock, then you need to be careful how much dose you're going to give. Blocks in cerebrovascular events. What are the clinical uses? This is where the meat lies. What do we do? How do we use this? So we can use it in several ways. We can use it as a sole sedative agent. We can use it as sole anesthetic agent. Then we use it as an analgesic, and then we use it as adjuncts as well. So as a sedative, it can be used anywhere in the hospital. It can be used in ICU. It can be used on the wards. It can be used inside the ward. Things like endoscopies. Very nice drug to use. That is where my experience comes from. So endoscopies can be facilitated by using this drug quite easily. You don't have to give a full-fledged anesthetic like we normally do. So this drug is quite useful in all these sedational procedures where you need a bit of sedation so that any procedure could be carried out, and hence the term procedure sedation. Whether that is gynae, urology, burn patients, pediatric patients, quite useful for burn patients to repeat dressings and all. And the same goes for, so two specific uses, obese patients and obstructive sleep apnea patients. So since the airway reflexes are intact and they are not losing their airway reflexes, plus this drug is not causing any respiratory depression, it's fairly useful in this group of patients. As a sole anesthetic agent, it has been used, so it has been properly described in the awake fiber optic. And I believe that this is going to be included in the latest recommendations for awake fiber optic as well, that is going to be released this year later on. But it has also been described for patients with COPD. And again, the advantage is that these COPD patients, they don't get any respiratory depression because of this drug, and the procedure gets facilitated by keeping them calm. Has been extensively described and used in North America for these carotid artery stentings. Then awake craniotomy, that is another indication. So there's a bit of competition between remifentanil and dexmedetomidine. So some people use remifentanil for these awake craniotomies, but most of the North Americans are using dexmedetomidine. Europe uses remi, North Americans use this. But this is how it has been described. Laryngoplasties, tracheomalacia, surgery for tracheomalacia, where you keep the patient awake, they maintain their own airway, and you're giving them a drug that is giving them a bit of analgesia, a bit of sedation, a bit of anesthesia, and yet they are able to maintain their airways. And hence those patients who do not want to interfere with their airways, they get to be operated upon. So that's a massive advantage in difficult airways. Then monitor anesthesia care, where again, as I've described, you have a cooperative patient who is able to respond to you. However, patient is pain-free and patient is sedated. So it all seems a bit magical, but it is once you you have overcome that initial period of understanding how this is going to work. And it causes much less respiratory depression than midazolam and fentanyl. And the quality of recovery is much better as compared to midazolam, especially benzodiazepines. So patients wake up quite crisp. So as a pre-medication, we can use it as pre-medication. Again, the same sort of principle. You use it from 0.2 to 0.7. So here we have said 0.3 to 0.6. But if we stick to one single dose, 0.2 to 0.7 for maintenance, that's fine. And then you can titrate in between the dose where I want to be. So pre-medication is the same usage, same drugs, same dosage. We can use it for stress attenuation, and the evidence lies in the fact that thiopental, these are animal studies, where they were able to demonstrate that 30% reduction in the thiopental dose. So how do we use this? In stress attenuation, single dose, 1 micro per kilogram, results in progressive increase in sedation. Does quite a few things. It blunts the hemodynamic response to laryngoscopy, then reduces the opioid requirement during the procedure, reduces the anesthetic requirements for induction purposes. And this dose provides hemodynamic stability at the time of extubation. So one of the indications is in difficult airways, at the time of extubation, give this medication 1 micro kg, 10 minutes before extubation, and you have a fairly smooth extubation. So the advantage you're getting is that the patient is not respiratory depressed, the patient is maintaining the airway, they have the laryngeal reflexes intact, and they are sedated at the same time. And they're not fighting the tube and all. So a big advantage. Bit of a learning curve here. Most likely we won't get it right the first time we do it, but we can get it right. So intravenous, intraarticular, intravenous regional anesthesia, all these indications are there as analgesics. As adjuvants, they can be used, since they work on the spinal cord as well, the receptors are present, so they can be used in regional and subarachnoid blocks. I do not know the exact dose, we'll have to find that out from the literature. So again, they can be used in adjuvants, in regional anesthesia, in local infiltration. So some people even locally infiltrate these drugs. And the idea is that since alpha-2 receptors are present in the peripheral nervous system, so there would be some effect on the peripheral nervous system and hence the local infiltration. So as you can imagine, any adjuvant is meant to increase the effect. So the increase in effect that we want is of bupivacaine. And hence the motor block and the sensory block. Motor block is supposedly spared and you get a much better sensory block. The non-anesthetic agents, non-anesthetic uses are extremely interesting. Physicians are very interested in this. So psychiatrists are using these in acute withdrawal, opioid, benzodiazepines, alcohol, prescribed as a short-acting agent in sleep-deprived patients. The sleep physicians are prescribing this medication. And then we have a user as well in the PACU, in the recovery area, where it can be used as an anti-shivering agent. So it does not cause respiratory depression. The sleep is more like a physiological sleep, no hangovers, beneficial in pediatric patient procedure, but I'm not going to say anything on pediatric, but to say the others. Less hemodynamic effects as compared to other sedatives, so fairly sparing when it comes to hemodynamics. No risk of dependence, no rebound effects. So most likely this is the future of anesthesia sedation. Most likely this is going to result in better satisfaction of our patients and improve. Is it going to improve in the outcome? Is it going to improve the outcomes in intensive care in Pakistan? We don't know, but we hope that it may contribute. Thank you very much.